All right. Hi, everyone. Thank you for joining us this evening. Tonight's presentation will be given by Dr. Phil Koehler, one of our PM&R physicians here at Rothman Orthopedics. If you have questions throughout the presentation, please feel free to enter them at the Q&A box at the bottom of your screen. Dr. Koehler will take time at the end to answer as many questions as possible. We may not get to all of the questions, but I know he'll do his best. So thanks again for joining us tonight, and Dr. Koehler, you can take it from here.
All right, thanks, Natalie. Hi, everyone. I'm Phil Koehler. I'm a physiatrist and interventional pain specialist here at Rothman Orthopedics, and I thank you for taking time out of your afternoon to listen to me talk to you a little bit about some of my passions here in medicine. My lecture tonight is going to be titled Interventional Treatments for Lumbar Radiculopathy, Sciatica, and Low Back Pain. So this is a little bit about me. I'm local to the area. I was born at Bryn Mawr Hospital, where I practice across the street. I was raised in Westchester, Pennsylvania, so I didn't make it too far away from home. I did all of my education in Pennsylvania. I completed my undergraduate degree at Lehigh University and then spent 7 years at Philadelphia College of Osteopathic Medicine, where I completed my master's and medical degree, and then completed my internship in preliminary internal medicine at Lankenau Medical Center, my resident in physical medicine and rehabilitation at Thomas Jefferson University, and then my fellowship right here at Rothman, where I've stayed on as an attending physician. Now, I see patients all over the Philadelphia area. The most care that I provide is at the Bryn Mawr office, but I also see patients in Glen Mills and Malvern, and I perform procedures at the media office. So I'm happy to see you across any of those locations. Some of the treatments I offer, I'm going to talk about tonight. Those are fluoroscopy-guided epidural steroid injections, hip joint injections, sacroiliac joint injections. I also perform ablation procedures, which are radiofrequency ablation and basivertebral nerve ablation, also called the Intercept procedure, which I'm going to talk about tonight. I perform some higher-level procedures such as spinal cord stimulator trials and kyphoplasty procedure for osteoporotic vertebral body compression fractures. And I perform electrodiagnostic testing with EMGs, sometimes perform osteopathic manipulation, and do certify patients for cannabis in the state of Pennsylvania. I have no financial disclosures. So getting into it, my lecture tonight, I hope to teach you a little bit about the most common interventional procedures you'll see in my practice and kind of across pain management practices. We're going to review the specific indications for these treatments, who is an appropriate patient for these type of treatments, hopefully give you an understanding of what the expected outcome is, and then talk about, although rare and usually very minor, the possible complications that you can experience from them. And to kind of outline, we'll talk about back pain and where these interventional treatments fit in place, and then talk about specific interventional procedures tonight, specifically epidural steroid injections, and then ablation type procedures with lumbar facet radiofrequency ablation, and then the Intercept procedure, which is also known as basivertebral nerve ablation. So one of the reasons you might be here tonight is because back pain is extremely common. If you haven't suffered from it yourself, maybe you have family members or a friend that have suffered from it. It will happen to 60 to 90% of us in our lifetime. And it might be one of the most severe amounts of pain you've ever experienced. That's sometimes the scary thing about back pain. Oftentimes when people have back pain, it could be almost the most debilitating amount of pain they've ever had, or equate to amount of pain they've had with another medical condition that's been a dangerous thing. But fortunately, most cases of back pain, they're actually not dangerous. They're usually not caused by some type of pathology like cancer, fracture, infection. Most back pain is usually mechanical, meaning it comes from movement. It's exacerbated by movement. And oftentimes is nonspecific, meaning it doesn't come from one specific structure in the spine. So part of my job is trying to figure out what's the cause of that pain. And fortunately, most back pain does resolve, whether we're aggressive with treatment or not. 80 to 90% of back pain will resolve in 1 month. It's very rare, about 10 to 20% of us that will go on to develop chronic low back pain. And surgery, maybe either fortunately or unfortunately, is almost never indicated for pure back pain. So it's one of those treatments that can be very helpful in certain conditions, but for pure back pain is almost never a great treatment for it. So the most important thing when we treat these types of conditions is getting a good diagnosis. And the most important thing to getting a good diagnosis is taking a good history and performing a thorough physical exam. Um, Imaging, incorporating imaging such as X-rays, CAT scans, or MRI is important for tailoring treatment, but it doesn't dictate our treatment. It essentially helps us kind of target our treatments. Now, there's plenty of research, and my patients probably have heard me talk about this in the past, but severe pathology on imaging doesn't always equate to severe pain. You can have severe pathology with minimal pain. Conversely, you can have minimal pathology on imaging and have severe pain. So it's all about the history and exam. And then sometimes we incorporate diagnostic injections. I'm going to talk a little bit about that tonight, but sometimes we use actual procedures to help make our diagnosis. So once we've made a good diagnosis, we talk about our 5 ways to treat pain. This is kind of a nice model I stole from the chief of our department that I think nicely breaks down the categories of treatment for pain. Um, the categories are, lifestyle changes, physical therapy with transitioning to a home exercise program, medications, the thing that I'm going to talk about mostly tonight, which are injections and ablation type procedures, sometimes surgery. And then I added the sixth category to his kind of model, which is kind of a complementary treatment algorithm, which is things that have a lot of, applications, but not necessarily a lot of research to back it. Maybe not our first line treatment, but that's things like osteopathic manipulation, alternative medicines like cannabis, complementary treatments like chiropractic care, cognitive behavioral therapy, psychology, acupuncture. So all those things sometimes are very appropriate and effective for patients. So I try and incorporate them when appropriate. But tonight we're mostly going to talk about injections and ablations. So kind of a brief overview of some of those categories, talking about lifestyle changes, diet can be important, weight loss. We talk about, extra weight around the belly, putting extra stress on the spine, which can not contribute to or can contribute to pain. The appropriate amount of exercise for patients. So it's important that patients are, moving appropriately, moving enough. I always like to say movement is medicine. Smoking cessation. There's plenty of studies out there that show smoking is affiliated with low back pain. So one of those things we're always trying to think about from a holistic standpoint is how can we optimize lifestyle? And then one of the things I like to talk about with my patients a lot are long-term goals. What's the patient goal? Do they have goals of exercise? Are their goals simply to walk better, maybe to play with grandkids, being able to garden, play golf? Those are the things that I try and set reasonable expectations and help patients understand maybe their limitations from what's going on in their spine. For example, someone with severe spinal stenosis, it's really not a reasonable goal for them to be a marathon runner. On the other hand of the spectrum, someone who's a power lifter who's had recurrent disc herniations and maybe has needed surgery, maybe they're not going to be able to lift heavy weights moving forward. So a lot of what I do is try and help people understand what's going on in their body and help them understand a reasonable goal. Now, if I can't stress this enough, physical therapy is usually the best short and long-term treatment for back pain. I kind of state it is creating an internal back brace. We're trying to essentially offload the elements of the spine, the vertebrae, the discs, the ligaments, the nerves that are usually your primary pain generators. So I sell therapy as a way to improve pain-free range of motion, strengthen muscles, and hopefully improve function overall. Now, it doesn't always equate to pain relief, but I think it's usually the best way to hopefully prevent things from getting worse long term. And usually it does help. And when I, prescribe therapy, I oftentimes try and help therapists out. I try and, one, specify diagnosis, talk about modalities that I think could be helpful for patients, such as manipulation, TENS unit, ultrasound. And then I try and specify the types of exercises that I think could be helpful. But working with a professional therapist is usually a great thing for patients because they have a ton of knowledge and experience and are great diagnosticians and clinicians in themselves. So I think they're an excellent tool. And this is usually your best long-term treatment. It's the only way to essentially stabilize the spine. Now, when therapy and lifestyle medicines don't work, sometimes we talk about injections, and that's when we have to set up who's the right type of patient for injection. So a lot of people suffer from not just low back pain, but low back with leg pain, which is commonly referred to as sciatica. Sciatica is kind of a misnomer because it's actually not a pathology. It's actually not a problem with the sciatic nerve. It's simply a term that we use to describe back with leg pain. The actual medical term for this is called lumbar radiculopathy. And what that is a pinch of the nerves in the spine that go down the leg and essentially form the sciatic nerve usually. And this is caused in patients by different pathology, and that usually is based on your age. So in younger patients, we typically see this being caused by disc herniations. In older patients, we usually see it due to arthritis, which causes spinal stenosis. It can be a combination of those two things, or sometimes from a condition called spondylolisthesis. But bottom line, this type of pathology can be treated with injections, which are going to be talked about in a little bit in the future. So I want to kind of talk about the anatomy a little bit and why people get pain in their back and leg. And I think if you understand the anatomy, it can be helpful for understanding why you're getting symptoms. So this is a nice picture that I like to show, which is a bird's eye view looking down the spinal canal. And this shows in the front on this left side a normal version of the spine, and on the right side a pathologic version of the spine. But on this left side, you can see this is what's called the intervertebral disc, which is kind of the shock absorber that exists between the bones in the spine, which are the vertebrae. If you look at this picture down here on the right, this is kind of what that unit looks like. You have a bone, you have a disc, which is the shock absorber, and then another bone. And those bones are linked in the back by joints called facet joints or zygohypophyseal joints. Those joints articulate just like any other joint in the body and are lined by cartilage. And the whole point of the disc and the bone is to form a canal that protects the nerves that come down the spine. Those nerves come down in a spinal cord that stops at L1. And then in the lumbar spine, in the low back, you have a clump of nerves that's called the cauda equina. So it's a whole bunch of nerves that come down. There's not actually a spinal cord there. And then the nerves exit out the sides and go to the muscles in the legs. Now, problems with any of these structures can damage those nerves or irritate those nerves. So typically what happens as we age, these discs, they dry out, they dehydrate. Genetics can predispose us to this. And then sometimes they dry out enough where they're predisposed to cracking. We've also learned that activities such as bending, lifting, and twisting can cause that disc to crack. And when that happens, it can be extremely painful and cause a lot of back pain because the disc itself has a lot of nerves in it. If it tears enough, it can actually leak the center part of the disc, which is called the nucleus pulposus. And this nucleus has a lot of inflammatory factors in here. So those chemicals can leak out and can irritate the nerves as those nerves exit down the leg. The chemicals themselves can be very irritating to the nerve. And then that jelly-like material, the nucleus, can actually push on the nerve. Now, the problem is if it pushes on the nerve enough, it can damage the nerve, and that's usually manifested in weakness. So if a patient has back with leg pain and weakness, usually that is a sign that there's damage to the nerve. And that's something where usually surgery is more appropriate management. So part of my job is trying to figure out if a patient has damage to those nerves. If they don't and they have those symptoms, that's where conservative treatments such as physical therapy, medicines, and injections can be helpful. Now, this is kind of a younger person condition, but what happens is when you have these disc herniation, it creates instability of the complex. So the one joint over top of the other becomes unstable. That puts more stress on these joints in the back, and there's extra movement. And what the body does when there's extra movement is it tries to stabilize things. And the way it does that is by depositing calcium and phosphate around joints to stabilize the joint. And when it does that, it creates bone spurs, similar to an arthritic knee or shoulder or a hip. And those bone spurs, called osteophytes, can narrow the canal as those nerves exit. It can also narrow the center of the canal. And that causes stenosis. And stenosis essentially is a Latin word that means pathologic narrowing. Now, the narrowing itself can damage nerves and can pinch nerves. But what happens is that complex becomes more stable, and that disc, that part that herniated out, never goes back in. So that disc becomes dehydrated and thinner, and the bones themselves can react to that and have pain. And that's what we typically refer to as degenerative disc disease. So it's not actually a disease. This whole process of developing a disc herniation, arthritis of the joints, degeneration of the disc, that's what we call lumbar spondylosis or arthritis in the spine. So this whole presentation are ways that people can develop back with leg pain. And when we get that clinical presentation, the way I can most effectively treat it are injections, which are called epidural steroid injections. I'm sure you've probably heard of this, maybe even had one before, but this is essentially an injection of cortisone or steroid into a space in the spine called the epidural space to help with pain, both back and leg pain. They actually work much better for buttock and leg pain more than back pain, but in this situation can be helpful for both. And epidural is sometimes a misnomer. People think all epidurals are the same. Well, epidural is almost like saying knee. It's analogous to an anatomic space. And what it is, if you look at this picture here on the right, is this blue area, which is a fatty layer that surrounds the nerves. So what we do is we put a needle into this area and we inject steroid that kind of floats around this fatty layer and covers the nerves and helps with inflammation, which usually decreases pain. Now, the steroid that we use can change, but they're all kind of versions of what we call cortisone. And they have different effects, but the whole idea is putting medicine in there around nerves to help with pain. Now, the way or the people who are most appropriate for these injections have to have a certain kind of clinical presentation. So, one, as we talked about before, there are people who have had back and leg pain, and they have to have some type of advanced imaging, meaning either an MRI or a CAT scan that shows narrowing around those nerves. Then the pain has to be fairly severe, at least 3 out of 10, and it has to have been going on for a little bit of time, at least 4 weeks, or they've failed conservative treatments. Or maybe they have such severe pain that they can't tolerate physical therapy. They aren't tolerating medicines, and it's kind of only an option. So those are the type of people who are appropriate for it. The way we get that medicine into the spine is done by different approaches. There's pretty much three main types of injections. The main one that we do in our practice is called an interlaminar injection, where you come through the center of the spine. You're accessing through this window. It's called between the lamina of one spine and the other. There's a ligament in there. There's also what's called a transforaminal injection when you're coming from the side where the nerves exit. If you look at this view on the side, this is where the nerves exit the spine. So we're coming right around those nerves. And then lastly, this caudal injection, which is an injection through the tailbone area. It sounds terrible. It's actually probably the least painful injection that I do. But it's not as close to the pathology, which is usually up higher in the spine where you see those discs. And that one can be used for people who've had previous surgery. Maybe they take blood thinners. So it's kind of a specific indication. But bottom line is, these are all different types of epidurals. And the way you get the medicine in there, that's where, it varies. There's a little bit of art in it. There's a little bit of science, but it can vary from time to time. So not all epidural injections are created the same. Now, what are the requirements for injection? Well, the day of the procedure, it's essentially a 15-minute long procedure. We bring you into a procedure room that has this special x-ray table where we lay you down on your stomach, and we use this machine called a fluoroscopy unit, which has a live x-ray in it. So this C-arm can rotate around the patient's body, taking different views of the spine, and we use an x-ray that goes through the body. It picks up here on the image intensifier, the camera. It's transmitted into a live video screen. And when I'm doing the procedure, I can take live pictures and see it up there. You can also take live video. And the neat part is when the needle's going into the spine, it shows up on the camera because it doesn't allow, it's metal, it doesn't allow the x-ray through it. And then we often inject dye in there to make sure that the medicine's covering the nerves appropriately. That all allows for accuracy and safety. Now, when we do this, this is not typically a painful process. We use very small needles, but usually what we do is use an extremely small needle and numbing medicine, which we call lidocaine usually. That is kind of similar to going to the dentist. So you get that pinch and burn, almost like a bee sting. It lasts a few seconds, and after that, it should not be painful. The needles that go through that area are about the size of an IV needle, longer to get down into the spine. And then we're, taking live pictures the whole time. These procedures are usually performed by someone like myself who's completed a fellowship. That usually that's either a physiatrist or an anesthesiologist. who's done 4 years of medical school, at least 4 years of residency, usually 5 years of residency, and then an extra year of fellowship, where they spend essentially a year learning to just do these procedures. You might think, what's the goal of this injection? Well, the goal is at least 50% pain relief for at least 3 months or more. The whole point is to calm down inflammation, help with pain while your body naturally heals this problem. And they can be repeated. It's not something that we repeat all that often. We're trying to do it as little as possible because injection of steroid into the body has its downsides. So decades ago, we used to do what's called a series of 3 injections, where the injections would be done right in a row, one every week. Research has shown that that doesn't improve results, and it's likely causing harm because we're exposing the patient to a lot of steroid. So now what we do is we do an injection, we see how the patient responds, and then we repeat it if necessary. So in a certain situation, if let's say they had no relief of their pain, you could change the injection up and do a different one 14 days later. But really what we're looking for is at least 50% pain relief for at least 3 months or more. And we combine these injections with, PT and medications usually to help with pain while the body heals. Now, you might be thinking, this sounds kind of anxiety provoking, sounds painful. Shouldn't I just do this with anesthesia? Well, it's been studied, and essentially, the American Society of Anesthesiology and Regional Anesthesiology recommend that none of these procedures are performed with anesthesia. And the reason for that is it actually can increase the risk and increase the cost of the procedure. In actuality, the reason why it increases the risk is because the patient can't respond to you during the procedure. So if something is painful, which it shouldn't be, they can't tell you that things are not feeling right. We also find that patients actually kind of move more during anesthesia. It's kind of like twilight anesthesia, almost being like disinhibited from being intoxicated from alcohol. So people move more. However, a little bit of movement during a low back procedure is not a dangerous thing for a proceduralist. So as I kind of talk about here, the injections that we're doing are from like L1 to L5. So people probably, have horror stories of someone was paralyzed from an injection. Well, that's almost an impossible thing. It's only been reported a couple times in the literature over decades. And that's because the spinal cord, which is this black stripe, is up here. It stops here at L1, and then the nerves come down. So we're kind of injecting around nerves, and those are almost like spaghetti needles. It'd be almost impossible to stab it with a needle if we wanted to. Now, when we put medicine in, some people do feel pressure in their back, butt, and leg from pressure of medicine going around a tight, irritated nerve. That's usually very transient. It usually gets better as soon as the patient gets off the table. So it can be a little bit of discomfort outside of that initial pinch and burn. But for the most part, these should not be a painful procedure. It should not be memorable. This is just some pictures depicting what I'm seeing when I'm doing those injections. So this is an X-ray view of the spine of a transforaminal injection of the needle coming in from the side, then taking a picture of the side of the spine, seeing that needle come in through the top of the canal where that nerve exits. Then when we get that needle in place, we inject the dye and we take a picture, and I can see that medicine covering the nerve nicely, not being taken away over here by a blood vessel. This is an interlaminar injection where I'm coming right down the center of the canal, right between the two bones. We take a different view to make sure we're not too deep in the spine, and then we inject dye. And then lastly, that caudal injection, which is through the tip of the tailbone and comes up around the sac of nerves there. Now, how effective are these injections? Well, there's been a lot of studies that show they can be very effective for pain relief. This was an article in 2010 by Nikolai Bogdok, who's kind of the grandfather of pain medicine. They studied 150 patients. They broke them up into 5 groups of 30 patients. They studied people who got an injection, epidural injection of steroid, epidural injection of anesthetic, epidural injection of saline versus just putting steroid or saline into the muscle, and they blinded the patients and they looked to see who got 50% or more relief at a month. And it demonstrated that the epidural injection of steroid was much better than anything else. Now, research has shown these injections work better for people who have more recent pain. So this study of 218 patients who got 50% pain relief at 4 weeks out showed that patients who had a shorter period of time from the onset of their pain were more likely to respond well to this. The average patient who did really well had pain for about 16 weeks or 4 months. The patients who had 60 weeks of pain didn't do as well. This is another study demonstrating that with 240 patients showing that if you had symptoms more than a year, you're less likely to respond to these. And overall, they can be very helpful. You might be thinking, well, what's the risk of these injections? Well, they're extremely low risk. The complications from these are very minor at most, usually. Unfortunately, the FDA has never approved these medicines for injection in the spine. And the reason for that is simply because pharmaceutical companies haven't really sponsored big trials because the medicines that we inject are generic medicines. And it's also difficult to kind of study these types of things. But the FDA also has looked at, complications of all types of epidural injections. And you'll see here, most of the extreme cases of problems with stroke or paralysis has happened from injections in the neck and cervical spine. But in the lumbar spine, it's almost extremely rare. There's been about 5 case reports to my knowledge over 30 years. And most of those were with injections of a type of steroid called a particulate steroid, which is a steroid that has particles in it, which can clog arteries if you get it in the wrong spot. So it's now standard of care to not use those type of steroids in transforaminal injections. The most common type of complication is increased pain, which has been quoted to be about 2% of patients. We're definitely putting medicine around tight, irritated nerves so people can have a little bit of increase in pain for a day or two following a procedure. It's usually not long lasting. Some people get very anxious and pass out from procedures. So vasovagal reaction, which is a sign of usually a normal, healthy nervous system, can happen. A lot of times for my patients that have anxiety about this, I will offer them benzodiazepines like Valium prior to the procedure. And then you may be most important, we have to consider the side effects from steroids. Maybe not a complication directly, but something that happens from steroids, which, long-term use of steroids are bad for our bodies. We're going to increase our blood pressure, increase our blood glucose, decrease our ability to fight off infection. They're going to thin our bones. So those are things we have to consider and why we can't keep repeating these injections. But overall, very safe, very effective treatment for pain relief in people who have back and leg pain, and our most common procedure. And then just to remind you that, these injections aren't designed to fix anything. It's not going to change the problem underlying. But what it does is it allows you to have pain relief while your body hopefully heals this. And then we allow our bodies to hold on to that improvement with physical therapy and hopefully prevent a recurrence of pain. So you might be thinking, Dr. Koehler, you didn't talk about my case where I just have back pain. What can you do for that? Well, there are procedures that work just for back pain without leg pain. And those are mostly our ablation type procedures. So I'm going to talk about 2 of them today. So you might be thinking about, arthritic type axial back pain, meaning pure back pain. In about 40% of patients, that comes from these joints in the back, the facet joints that get irritated when we bend backwards or twist. And that happens because that increases the load of those joints. So as we develop arthritis, those joints can be very painful, usually with standing and twisting. There's a procedure called a radiofrequency ablation that can be highly effective for this type of pain. There's other names for it, radiofrequency neurotomy, facet ablation. But the bottom line is through a needle, we conduct electromagnetic energy and heat to destroy a target tissue. And what that target tissue is actually a small nerve called the medial branch nerve that tells your brain that those joints hurt. It's the sole purpose of that nerve is essentially to just tell your brain that those joints hurt. The cool part about this procedure is it lasts much longer than epidural steroid injections. There's clinical benefit usually of a year or 2 and possibly up to 5 years. And because of that, it's the second most common procedure that we perform in pain clinics. Now, one of the drawbacks of this is we can't just go around, start burning nerves in people's spines. They have arthritis. We think they have this problem. What we do are diagnostic injections to figure out if you're an appropriate candidate for this procedure. And how that works is just like an epidural steroid injection under X-ray, we guide a needle down to the joint and we numb up the joint with a strong anesthetic that lasts typically 3 to 6 hours. Then we have the patient go test out their pain, do the things that aggravate them, bend, lift, twist, any of those type of things, stand, walk. And we're looking for them to get dramatic pain relief that day while that anesthetic is working. It should be greater than 75% pain relief. If it gives them good pain relief, we actually have to repeat that procedure again, usually 2 weeks later. And we actually have to repeat it with a different anesthetic. If it gives them great pain relief again, it means they're a great candidate for the radiofrequency ablation, and they have a greater, essentially, than 75% chance of that procedure giving them good pain relief. Now, you might be thinking, what is that medial branch? It sounds bad. You're burning nerves. Well, as I talked about, that nerve essentially just goes to the joint, tells your brain that it hurts. It's a branch off of the spinal nerves. And the nerves that go to the legs and give you strength in your legs or cause pain down the legs are more anterior or forward in the spine. So we're using the X-ray camera to target these nerves and make sure we're avoiding the nerves in the front of the spine. So it's not a dangerous or usually painful process at all. We use specific anatomy here, different views to target these nerves. And each one of these nerves actually goes to two joints. So you can deaden one nerve that goes to two different joints. And then the reason why we have to do two sets of blocks is because the research really supports it. There's been a couple studies that have shown you're more likely to get better percent of pain relief, longer duration of relief. The patients are more satisfied. We reduce pain medicine when we do two blocks. Now, there have been studies that compare doing no blocks, one block, or two block, and it's shown that you're likely to get relief of more patients when you just essentially burn everybody's nerve. But the percentage, meaning the accuracy of the patients that get good relief with doing the two blocks, is much higher. Consequently, this probably goes against reimbursement rates. So insurance companies are charged more, three separate procedures. But it's usually the best way to go about it with these patients. They're more likely to do really well. This is kind of a picture of what that looks like on the X-ray camera. You can see we're bringing needles into the edge of what's called the facet joint there. And we're avoiding this big open space here, which is where the nerves are. And then through those needles, we hook up a wire. And we actually not only make sure we're in the right spot with the X-ray camera, but we test the nerve by stimulating through this wire to make sure we're nowhere near the motor component of the nerve. So we test where if that needle was close to the nerve going down the leg, it actually will make the leg jump. So during the procedure, I test the nerve and I watch to see if the leg's moving. I ask the patient, is your leg moving at all? And we double check. So that's one of our safety checkpoints for this. Now, when you get a good, successful procedure, it usually takes about 3 to 6 weeks to fully kick in. But as I said before, people get great pain relief, improved function. They decrease their use of medications, and they typically last for a long period of time. Now, if the pain returns, you can repeat it. They can be repeated every 6 to 12 months, but that's not ideal. And they're very low-risk procedures. Most of the complications that come from this is from the needle going through the tissues, which is a little bit bigger needle, so you can get a little sore. You can also, have a little bit increased risk of infection. There's, in an untrained person or someone who has very poor anatomy, there's a possibility of damaging the nerve that goes down the legs, but that's extremely rare. And then neuritis, which is kind of a sunburn-like sensation or numbing of the skin, can happen, but that's pretty rare as well on the lumbar spine. And it's usually not a bothersome process for patients, but something we try and avoid, usually by injecting. Research has shown they've been very effective for a long period of time. This was a nice study done in 2015 that looked at 62 patients and followed them over 5 years. And it showed that, about 40% of patients got 2 to 5 years of pain relief from these. And a small subset, about 18%, got greater than 5 years of pain relief. Now, what was shown is in the patients that had a return of their pain, who underwent a repeat ablation, which fortunately doesn't require to do the blocks again, they went on to have an additional 10 to 16 months relief. So meaning if you had an ablation and you got 2 years of pain relief and your pain returned and you underwent a repeat ablation, you're more likely to get about 3 or more years of relief after that. So highly effective procedure for pure back pain that's worse with extending your spine and twisting. So you might be thinking, well, Dr. Koehler, I have back pain, but that doesn't describe me at all. My pain is mostly when I bend and I lift and I twist. And I'm not that old. Maybe I'm in my mid 40s. I don't have bad arthritis. What do you do for my pain? Well, historically, that's been the most difficult patient I treat. Back pain is hands down the most difficult thing that I treat in my practice because there's not a lot of great treatments for that. For a long time, we told these patients, you kind of have to live with this pain. We do the best we can with therapy, medicines, complementary treatments. But, it's a very difficult thing. And that's usually when we have pain coming from those discs. But fortunately, over the last 5 to 10 years, there's been a new procedure that's came out that's been revolutionary in my practice, and that's called the intercept procedure. Intercept procedure is another ablation type procedure, but we're burning a different nerve. We're burning a nerve called the basivertebral nerve. And the patients who are appropriate for this are patients that have chronic low back pain that's typically worse with bending, lifting, prolonged sitting. And the average patients in the studies were 46 years old. So you're not talking about your 60, 70, 80-year-old patients. Typically, those age patients can be a candidate for this procedure, but the most common patient is middle-aged. And what it is a nerve that comes in the back of the spine here and enters the actual bone and branches out like a tree. It gives branches to the edge of the end of the vertebrae. For a long time, we didn't think the bones could be painful itself, but we've learned that people actually develop pain coming from the bone when they've been having chronic disc problems. So we talked earlier about how those discs release chemical mediators of inflammation. Well, not only can the disc leak back into the canal here and push on nerves or irritate nerves, it can leak up into the vertebrae. And if that's been going on for a long period of time, it actually can create changes in the bone that we can see on MRI here. That's what this white change is. That change was described by someone called Dr. Modick, and we see those changes actually on MRI, different views of the MRI. So someone who has dealt with chronic low back pain, works with bending, lifting, and twisting, who has these changes on their MRI, might be a good candidate for this procedure. Now, how does this procedure work? Well, it's a little bit more invasive than everything I've talked about before. And the reason for that is we're trying to get a needle into the spine in the center of the bone. And the way we do that is essentially hammering a needle. So we make a small incision in the spine, we hammer a needle down into the bone. And I do these procedures under general anesthesia. It takes about an hour to do. Some physicians are starting to use twilight anesthesia. But what you do is you hammer a needle that has a little stylet that comes out and hooks, and you get right to the tree trunk of that tree that branches out, which is a nerve, and you burn that nerve. It creates a circular lesion, and that nerve dies back over a couple months, usually 2 to 3 months. And it's a one and done procedure. The procedure's only been around about 10 years, but it shows that there's no need to repeat this for now. It's been an incredible procedure because it's been revolutionary in the amount of pain relief we get people. So there aren't a ton of data with this, but the initial data that was published, which were 2 randomized controlled trials, they studied about 225 patients and 106 patients. And when I saw this initial data, it was almost too good to be true. And the data is held up over 5 years. So the patients in the initial trials were followed over 5 years, and the amount of pain relief they got has been consistent at 5 years out now. And what we showed is patients with chronic low back pain who had this procedure, 2/3 of them got greater than 50% pain relief. The incredible thing is about half of them have had 75% or more pain relief. So the most rewarding thing for me in practice in the last 2 years since I've been doing this procedure is having patients who have had decades of low back pain, who I perform this procedure on, come into my office and tell me that their pain is essentially cured. They are pain-free. They're able to bend and twist and lift their grandkids or go exercise, run, and they haven't been able to do that for a long period of time. So it's been extremely rewarding. Now, there are a third of patients who don't respond to this procedure, and it's difficult to predict who's going to be the ones who respond so well and those that don't respond. But it's also an extremely safe procedure. Usually patients have a tiny bit of soreness after the procedure. I usually prescribe a few days worth of pain medicines. I think about a quarter of my patients actually end up using it. The procedure itself usually takes a couple months to fully kick in, but I've had patients wake up without pain. And in the initial trials, the most serious complications were people who develop leg pain. That's usually from inflammation from going through the bone, and irritation of those nerves down the leg. And in all of the patients that experienced that, which was about 5%, it all went away within 2 months' time with use of oral medicine. So no one really needed surgery or anything like that. There was no major complications. There was no nerve damage. There was no infection. So overall, very safe procedure. Unfortunately, it's not being adapted by a lot of insurance companies yet. It is approved by Medicare. The hardest thing I found with this procedure is getting it approved by insurance. But when I get it for the right patient, it's been highly effective. And as I stated earlier, the 5 year data for it is incredible. This was a recent article in December that showed that those initial patients in the initial trials have done well as they did from the first year now to 5 years out. So that was a lot of information, but I hope you kind of get the gist of this. But the most important thing is getting a good history and exam for a diagnosis. I want you to remember that typically back pain, although it might be the most pain you've ever experienced in life, does resolve in time for the most part. Our body does a great job of healing. An MRI isn't always needed for treatment. It does help us tailor our more aggressive treatments, such as injections and ablations, but oftentimes it's not necessary for initial treatments. Physical therapy is our best short and long-term treatment. We can use medicines, which I didn't really talk about too much, but that's almost its own lecture in itself. And then when all that fails, that's where someone like myself has some tools in our toolbox to help you with your pain, such as epidural injections, ablation procedures, and then referring you for surgery when it's appropriate. Surgery has a great use in patients with lumbar radiculopathy and sciatica, and sometimes that's the most important thing to do. So, I think getting to see someone who has expertise in spine care is the most important thing. And working with a physician who you trust and can develop a nice rapport with, and help them understand what your lifestyle goals are the most important things for being successful in treatment of back and leg pain. That being said, these are my references. I wanted to leave a little bit of time for some questions here. I see a bunch coming through in the Q&A, so I'm just going to go through quickly. I apologize, but I'm sure I'm not going to get to all of them here. So I'm just going to take a quick look here. So someone asked, who do I go to for an exercise plan? Well, I think physical therapists actually have a lot of knowledge about, how to transition from, physical therapy from a rehabilitation standpoint to an exercise plan with a lifestyle management. And I really rely on my therapist. So when I see you in the office for a 20-minute appointment, it's not enough time to figure out what is going to be needed long term. But when you work with therapists, 3 times a week for 6 weeks, which is usually what I prescribe, they're going to get to know you and figure out what your limitations are. They're going to figure out, hey, does this person have a bad hip or a bad knee that we need to offload? And they're going to be able to come up with some ideas. But typical exercises that are low impact on the spine. I love swimming, prescribing for my patients. I'm not a big swimmer myself. I love cycling because there's not a lot of bending with that. Tai Chi has been clinically proven to help with pain. So those are some ideas that I like. So someone asked, how do you manage positioning a patient on their stomach during these procedures? Well, sometimes that's where anesthesia can be helpful. So if someone is not able to lie on their stomach, sometimes going to a surgery center and having a team that can help position patients, using some sedation can be helpful, or at least having a team of nurses and anesthesiologists to help, that can be helpful. So someone wrote, epidural injections are for pain, will not cure arthritis in the spine. So the body is not actually healing itself. That's correct. So we're not actually able to fix arthritis. Unfortunately, there hasn't been any real research that's been discovered to fix arthritis. There's a lot of people out there trying to inject stem cells and regenerative treatments, but the research hasn't really panned out on it. So we're really managing symptoms, but the body can essentially stabilize arthritis, not make it worse. So that's where I think movement is medicine, and pain itself is almost its own problem. So curing pain itself, which can become a cyclic problem, is I think important. So someone asked, what if someone's had a bunch of injections, but the pain still exists? Is there anything you can do for spondylolisthesis? Well, a lot of times that's where my surgical colleagues come into play. So you have to make sure you're working with a pain management specialist who, knows when it's appropriate to refer to surgery. And usually that's the case where surgery is important. Uh, Someone asked, do I accept workers' comp insurance? I do accept workers' compensation. Someone asks, how is treatment different if I have osteoporosis? Well, osteoporosis, fortunately, usually doesn't cause pain. It can predispose you to fractures, and that can be extremely painful. So, I would say the only way that I really change treatment for osteoporosis is I keep in mind trying to avoid the patient being exposed to things that can be detrimental to their bone density, such as steroids. So, those are the type of patients we have to be very careful with. So someone asks, what is the most effective treatment for SI joint pain? Well, in my experience, SI joint pain, they quoted about 10% of pain. SI joint pain is usually a product of another problem. So usually a product of radiculitis or radiculopathy. So, treating that underlying problem is the most important thing. But if it's truly coming from the joint itself, usually physical therapy is the most important thing for that, making sure there isn't an autoimmune condition. But injections can be helpful for SI joint pain. But like I said, it's usually not the main problem. Sacroiliitis is extremely rare, actually. Someone asked, can I repeat the symptoms that can make you a candidate for intercept procedure? So it's essentially patients that have pure low back pain, no leg pain, back pain that's exacerbated by bending, lifting, twisting. It's been refractory to any type of conservative treatment, physical therapy, medications, chiropractic care, injections, and they have to have those modic changes. So chronic back pain with those modic changes on MRI. So not a lot of criteria to meet for the intercept. And someone asked, does it work if you have leg pain? It does not work for leg pain. Um, Someone asked, what are my thoughts on chiropractic care? Well, I spent a whole extra year in osteopathic medical school learning manipulation, treating patients with manipulation. I think it has its role. I think understanding when it's probably most important not to use manipulation is the one thing that I stress. I'm the first one to prescribe manual therapy, and I think people who do it a lot can be very helpful. And I think, just like physicians, chiropractors all have certain tools and there's certain restrictions. Some people like to do certain types of techniques that can be, highly effective or sometimes highly ineffective in the wrong hands. So I think it's important you get with the right practitioner for a chiropractic care. And more importantly, probably see a physician to make sure there's nothing dangerous about why you shouldn't have manipulation done. Oh, and someone asked, there was some news years ago about contaminated steroid injections, compounded injections. Is this still a concern? Well, it's always a concern. We're only as good as the materials we use. So that was a fungal outbreak that was in a compounded pharmacy. Those pharmacies supplied a lot of steroids, so there's always risk with those type of things. That's why we do the best we can using sterile technique. We try and purchase medicines from highly reputable companies. But there's always a risk with these things. That's why we're always performing surveillance of our medicines. We're recording what the dates and lot numbers of our injectates are. There hasn't been, to my knowledge, any problems with infection since that initial problem, but something we always keep close watch of. Um, Someone asked if I ever use general anesthesia for an epidural. I personally don't. I feel the risk of general anesthesia highly outweighs the risk of doing an injection with either local anesthetic, meaning injected numbing medicine, or twilight anesthesia. Someone said there aren't many physiologists, or I guess they mean physiatrists around. What type of doc would be best? I think spine surgeons are never a bad option. There aren't a lot of physiatrists trained in pain management out there. I think anesthesiologists who are trained in pain management are pretty good at these type of management. It's kind of what we spend our time in fellowship doing. Um, a lot of questions here, so I'm hopefully getting to seeing like 50 or 60 questions. Someone asked, is physical therapy and strengthening important and are needed for recovery after injection RFA? Yeah. So therapy is the most important thing. That's how we stabilize their spine and hopefully prevent aggravation of those pain generators. So, epidural injections and RFAs, it's purely for pain relief. And as I stated before, therapy is really the hallmark. So someone asked, what causes weakness when walking and what procedure will help? Well, weakness can be a result of multiple things. There can be pain inhibition. So some people, for example, if they have a painful hip, they feel really weak in their leg just because putting pressure on the leg inhibits their muscles. But if it's truly from neurologic weakness, meaning there's damage to the nerve, the only thing that can fix that is either your body naturally heals it, which can happen in acute situations such as a disc herniation. The body can heal a disc herniation, but if it's been going on for a long period of time, that's usually where surgery is most appropriate. Someone asked, how often can you get injections? Well, there's no hard and fast rule for this. Insurance will only approve 3 to 4 a year, and they're doing that to protect patients. You have to determine, how much steroid the patient's been exposed to. So you have to think about not only the exposure of the steroid in that specific injection, but how much have they been exposed through their entire body? Are they getting injections into their knees, their hips, their shoulders as well? And then you have to consider if you're needing them that frequent, are they really even working that well? So that's something I try and figure out with my patients. Maybe using a different type of epidural injection is a better option to try and get longer lasting relief. But that's kind of a little bit of the nuances with it. So someone said, my last injection gave me a lot of pain in my leg at the time of the injection. This never happened before. Why is this? Well, when you're doing these procedures, you can't actually see the nerve. So we're using the X-ray guidance to get the needle around a nerve. We're not actually injecting the nerve. So we're trying to get the layer of fat around it called the epidural space. Now, there could be a bunch of different reasons why one injection is more painful than another, and I try and explain this to my patients. I could do the same injection, one time it doesn't hurt, and the next time it does irritate them. It typically only hurts for a short period of time, but one reason for it is maybe that nerve's much more irritated and inflamed than it was in the past. So if you have something that's really hot and irritated, that nerve doesn't like it when it sees that medicine's there. Hey, watch out, I'm here. So that's part of it. That medicine's going in around an irritated nerve. The other thing is the approach. So sometimes we're putting medicine around a really narrow stenotic area, and it really pressurizes the nerve. So that's the part that's difficult to tell with patients. So a lot of times, if you take your time and you're gentle about it, you can avoid that. All right, a lot of questions here. Someone asked, are there weight restrictions for these procedures? There's no real weight restriction. I think, you have to be considerate of, does someone who has, extra tissue around their spine make it more difficult to visualize the problem? So that is something to always consider. It does make the injection difficult because it's more tissue for the X-ray to penetrate, but it doesn't mean there's a restriction necessarily. Someone asked, which procedures will Medicare cover? Well, everything I talked about today, Medicare does cover. Sorry, a lot of questions here that are very specific. So I'm always happy to see in the office. There's a lot of very specific questions. Uh, Someone says, is it common to hurt on one side more than the other? And would it be okay to just have an injection on that side? Yes, very appropriate. We sometimes we'll do this where we will, do an injection on one side of the spine, maybe a transforaminal injection or an ablation on one side, and see how the patient does with it. If they did well, then sometimes we come back and do the other side. But I think we're kind of running out of time here. It looks like Natalie just sent me a message.
Yeah, thanks, Dr. Kohler.
Yeah.
Thank you so much. That was very informative. Thank you all for joining this evening. I know there were a lot of questions. Dr. Kohler, thanks for answering a lot of them. Some that are a little too specific, to the case, very, very detailed. I know Dr. Kohler would be happy to see you in the office. A couple people were asking about appointments, so I did message them and say, you all have my email. So please feel free to shoot me an email if you need help scheduling an appointment. I am happy to help facilitate that to see Dr. Kohler. Again, Dr. Kohler sees patients at our Bryn Mawr, Media, Malvern, and Glen Mills offices. We did record this, so we will be sending it out to everyone who registered. So all of you will receive it, as well as anyone who registered and wasn't able to log on tonight. So thanks everyone. Thanks, Dr. Kohler. Thank you so much.
You're
And
welcome.
thank you
Thank you.
everyone for joining us tonight. I hope you have a great night.
Thanks for your time. Thanks, everyone. Take care.